Welcome back. You're with Luther Nyrenda, also known as Anesthesia. Today we're going to be doing a video on a clinical survival guide. Just kind of talking with you guys about clinical, what to expect, what I do, do's and don'ts, and just trying to get you through it. So like and subscribe, and I hope you like what you hear. So my first impressions of clinical rotations were overwhelming. The first time you go to a clinical site, you're just very green, very nervous. You don't know anyone. You don't know where to go. The email you get before you go to the clinical site is terrible. You might get a text with not much detail. You meet whoever your clinical coordinator is or somebody, a point person that morning. Hopefully you have somebody who's an upperclassman who has gone to that clinical site. And so they kind of tug you around in the early morning, but get there early. You won't know what kind of case you're probably going to be in that day. They'll kind of just throw you into a room, but get there early and do all the simple things to make that day feel as normal as possible. So have whatever breakfast you like, drive in with your favorite song. Once you meet your clinical person, shake their hand, have a big smile, be eager, but not overexcited, and just kind of follow their lead. They'll have you change into scrubs. You get your little hat on. Maybe you have a fun ditzy hat that you like to wear that feels familiar to you. And then they'll probably just throw you into a room. And I think that is one of the biggest nerve factors, because the introduction you get to whoever your preceptor is for that day is just going to be like, "Hi, I'm Luther. I'm with you today." And they're going to be they're going to turn around and you're going to see horns coming out of their ears and fire burning around them, because they're just so excited to have you as a fresh new student. So guess what? The day has to end at some point. And once you get past that first day, you'll go the second day, third day, and eventually you get comfortable. And then as you get comfortable, you go to the next clinical site. And even as a senior now, my first day at a clinical site is always the worst day. You're just like, oh my gosh, what's the code to the locker? Where's the bathroom? Very important. Can I steal snacks from this random desk? Probably not. Where's my pen? You just keep doing what you're good at. So anesthesia doesn't change at each place you go to, right? The dose of propofol isn't changing as you go from one site to the next site. What changes is just the personalities that you encounter, maybe how they do things, and timing of surgeries and things like that. You'll always keep having first impressions. You'll always keep getting the nerves about them, but embrace it and stick with what's comfortable, and it all gets a little easier. I think with handling nerves on the first day, it's kind of just like what I was talking about. Just do what is familiar to you, but also truthfully, don't run away from your fear. Your fear is real, and it's also something that is keeping you alive, and it's keeping you in check. When you're intubating somebody, you get a little nervous. That's a good thing, okay? Especially when you're first starting out, you should be a little nervous. Eventually, you won't be nervous, right? But that nervousness comes from I don't want to, break their teeth. I don't want to cut their lip. I want this tube to actually go through the vocal cords and not go through the esophagus. That would be great. I also want to make sure I tape this well so it doesn't slide out. Those are all good things we're nervous about. And one thing I remember, I was with this clinical preceptor, and every time I was with this guy, I just fumbled the ball. It was really early on in my training. And one day I just looked at him and said, "I don't know why, but every time I'm with you, I just get nervous." And I'm like, it's not a you thing. I don't know what it's about, but I just need to say it out loud. And he was just like, okay. And from that point on, it's been fine ever since. So if you try to run away or hide from your nerves, I think that they'll eat you alive. But I think if you embrace them and take them head on and welcome them, I think that things get better. I think the most challenging cases I think this will surprise a lot of people, is the most challenging cases are the cases that you're with somebody, whether they're anesthesiologist or a CRNA, and they are difficult to work with. Maybe they're considered mean or really picky. They want things done exactly their way. I think those are the most challenging cases. They're not the cases where I'm doing a triple bypass or I'm doing a abdominal aneurysm, or we're doing a high risk C-section, or we're doing twins. Because if you're with the right people, your favorite nurse in the room, your favorite surgeon, you're working with your favorite preceptor, there is absolutely nothing in front of you that can harm you. And you feel so lifted and so grounded, and which those two things are contradictory. Don't worry about that. But you just feel so in tune with who you are and your skill set, and that you can rely on the people around you, that your performance is way better than when you're with somebody who is questioning everything you're doing, or makes you just feel like they're pouncing on you, waiting for you to make a mistake. Those are incredibly hard days. The days where you're with the right person, anything could go through those OR doors, and any plan could change, and you would be just happy that you're with those people. This is the point where the YouTube ads will play. And this is also the part where my friend Ty told me to say like and subscribe. So please like and subscribe. I think what tips would have helped me on my first day would be breathe. And then after that, take another breath. It's not that serious. You are literally doing everything you have to do by just showing up early. Nobody's expecting you to go into the OR and be able to mask, intubate, put an IV, do a central line, and the A line. Oh, don't forget, make sure your gas is on well. Oh, you didn't set up the drips? Do that too. Like, that's not what is expected of you. As you go through clinical, there's certain things that you should be achieving little by little. But every day, from that first day you go, just work on something. Pick one thing and work on it, you know? I think a lot of times people get too in their head, and they're like, oh man, I missed that IV. But they don't think about the fact that, oh, like you went and you saw your patient, you talked with them, and you were able to give a good, thorough report to your preceptor about what you think we should do for the case. Or you didn't think about the fact that you intubated them without having any real issues or assistance. Or, you know, you had a really great case, but then on extubation, they're coughing a bunch. Whoop-de-doo. I think that if all of us in any aspect of our life, if we counted the wins against the losses, the score looks pretty good. I think that we just weigh our losses way more than our wins. And I think that's what's really hard about it. So your first day is just take the wins as they come, right? You got up early. You didn't sleep through your alarm. Thank God. You got to clinical. You put your pants on right. You made sure to bring a pen and a stethoscope to the OR and a smile. And I think that if you can do those things your first day, everything else gets a little easier. I think the best way to build rapport with your preceptors or other staff members is, I think this goes back to separating the student from the person. People neglect that in our profession, in a lot of aspects of life, is your personality can take you farther than your skills. And I don't think a lot of people think about that too much, and they wonder how somebody who doesn't have a lot of talent can go really a lot more further. And the answer is networking, conversation, connection. And building rapport in the OR is about connecting with those people in the OR, right? You're going to go through difficult, challenging things in the OR. But the relationship you build outside of the OR or during cases helps to make those difficult times better, and the communication gets better as well. A good example is my program director in his class. They would write down in a document like preceptor's favorite things. So each student, when they're with the preceptor, would talk about that favorite thing, and the preceptor would just yap on about whatever that thing they liked. So if it was fishing, the student would pretend that they liked fishing, and your day gets a little bit better that way. Because people just want to connect with other people. As simple as that. Once you do that, what ends up happening is they get to trust you a little bit more, right? And as your skill sets build and you become better at intubating, you become better at IVs, clinical judgment, making certain calls, knowing when to have humility and ask for help, the rapport just goes to the ceiling. So there's different aspects to it, right? It's the social aspect of what's something my preceptor likes that I also like. You don't have to like it because you're trying to get through their day. And how can I meet them? It's also getting better at your skills. Then it's also having the knowledge, because you could have not the greatest skills, but if you have a good knowledge base and you can communicate that well, I think that reads a lot more to preceptors than if you can, intubate just anybody off the street. I think that if you're more prepared and able to instill trust into others, they will entrust you with these patients and you'll have a better day. All said and done. All right, so I'm going to talk to you guys about how I feel like I'm successful clinically and what works well for me. So I think that some people do the whole day before, read into the charts, write up a big care plan, and, try to splurge all that information out to the preceptor. I think that early on, that's important to make sure you're doing your care plans, doing the readings and things like that. But as you become better and more proficient, you'll find yourself going to clinical the morning of. And what I do personally is I'll go a little bit earlier. I'll get an email about what kind of case we're doing. So if it's GI, if it's going to be cardiac, if it's going to be obstetrics, if it's going to be gynecology, I have an idea in my head. Okay. There's a lot of ideas that are spurting out, but I don't have a clinical picture of my patient yet. And that's very important. And I'll tell you why. And so I'll go to clinical, get there in the morning, get there early. I'll go to my room, do my machine check, open up the chart, open up the Pyxis or the Omnicell, which is just where we store all of our medications. And I'll pull up the general things that I will need. For example, if I'm doing a robotic, gynecologic, or gastrointestinal procedure, I know that we're going to be using laparoscopy to insufflate the stomach. So I need an OG tube, right? If it's robotic, they're probably going to tuck the arm, so I'll probably need a second IV. So these are very standard things that I will need for this case. If I'm doing a cardiac case, I would want a bigger tube because they're more than likely going to the ICU afterwards. We're going to need other access points. Are we going to be doing a pulmonary artery catheter? Are we going to be monitoring CVP pressures? Those are all very standard things that you're going to use for those type of procedures. Then once the computer's opened up, I'll start reading about the patient. And I'll go through and I'll click, I'll get their height and weight, allergies. I'll do a quick chart review. I'll look at their cardiology tab, images, so anything relevant like C-spine injuries or hardware. I'll look at a chest x-ray if they recently had one. Maybe they had a recent admission for something, so maybe they're a little bit sicker. I'll look at their medication list. So I'll be looking for like GLP-1s, so like semaglutide, Mounjaro, things like that. And then I'll look for blood thinners or anticoagulants that they might be taking. And obviously there's other medications that you're obviously looking for as well. I'll look at what's called a snapshot. Some places have it. It's basically like a quick rundown of the patient. So it has like their demographics, it has medications, previous anesthetics. So I'll click on that, look at their last anesthetic, try to get an idea, previous surgeries they might have had. And I'll make sure to look at within their cardiology tab. I might have forgot to mention is I look at the EKG, carotid duplex. I'll look at their echo if they have it, a stress test. And then I'll kind of go into my notes and then read through an internal medicine note or a recent visit note, something where like there's an H&P, so a big picture of this patient. And what that does is it quickly gives me information. As I was going through clinical, I would write down some stuff here and there, but now I just kind of keep it in my head. And it's just like my brain is just circulating through all this information over and over again as I'm getting everything else ready. Then I'll go to pre-op and I'll meet the patient. Maybe I'll put a pre-op note depending on the facility I'm at. And I'll ask them questions, and it's a time for me to instill trust into them about what we're going to be doing today, what they should expect, what things, and alternations can happen within the anesthetic plan. And what I always try to leave them with is a sense of, this person cares for me. Everyone in the room cares for me. I am the most important person right now. There's 2 times you should feel very important in your life: your birthday and when you're getting surgery. And I always tell people I have one simple goal, and that goal is to make sure that they, as the patient, see the end of the day, and that I also see the end of the day. I think that keeps things grounded, keeps me level-headed, and helps reassure them what we're really there to do. The surgeries don't matter. And what I mean by that is, whether you're doing a heart surgery, you're doing a lipoma, you're doing a little skin excision, if you're doing general anesthetic, all the way down to a MAC case, people are scared. We are there to reassure them and to keep them safe and figure out the best way to do that. After I see the patient, I'll go back to the room, and usually I have gone quick enough that me doing the chart review, getting my machine ready, getting my medications ready and drawn up can take me 15 minutes, if that. I mean, that's me really pushing it. And that's even if I have to get drip set up or whatever. Seeing a patient in pre-op can be 5 to 15 minutes. I try to really make sure I leave them feeling a little better about, what's going to happen and what's going on. And then I check in with the nurse, make sure they don't need anything, go from there. And then usually there's some downtime, so maybe I'll go, take a little walk, get a cup of water, just go on a walk. And when that's appropriate, I'll go and talk with the CRNA or the anesthesiologist that I'm working with that day and just kind of relay my findings, bounce some ideas off them, see if they're happy with everything. And that's how I keep my day really routine, really disciplined, do the same thing every time. Try not to divert too much from the plan that I have set. But also, you also want to be very flexible in that plan. You might think you're going to do all these things and it's going to go great, but you don't know that. You have no idea. You never promise somebody a certain outcome. Never say that we're only doing it this way. Let the flexibility of what can happen with your patient and what your patient might want, and the nuances of what maybe the surgeon requests, to help guide you. And at the end of the day, the biggest thing is to keep the patient safe. So however you accomplish that's the most important thing. I want to thank you guys so much for watching and staying tuned with us. And by us, I mean me, myself, and I. Just make sure you take the time to like and subscribe. It really helps us to make some more videos, and we really appreciate it. Follow me on Instagram, Anesthesia. There's some content on there as well, and hopefully we can get some more stuff out to you guys. Hopefully you're enjoying it. Hopefully the holidays are treating you well. Hopefully it's cool enough for the burnout not to get you as well. So see you guys next time.